Right. Good afternoon.
Good afternoon.
Welcome to our third session in our series that we have been putting on through the Ghana College of Physicians and Surgeons. This is a series focused on faculty development and medical education. I am Dr. Rockefeller Otang. I'm an emergency physician here at the University of Michigan, also a fellow of the Ghana College of Surgeons in the Faculty of Emergency Medicine. Today, we will be joined by esteemed faculty who have specific expertise as it relates to our topics today in developing medical education. We are joined today by the Vice Rector, Dr. Henry Lawson, along with Dr. Emil Reindorf, who will help me in moderating this session. We hope that you have enjoyed the prior sessions, but today we will be moving forward with new topics that we will be exploring. I'm going to share my screen real quick and show you a little bit about what we're going to do today. Today, we're going to talk about faculty development in medical education. We hope to inspire a cohort of clinical faculty who are going to get further engaged in medical education as we move forward. We want to develop a cohort of clinical educators who are capable of disseminating best practices in medical education to other instructors. We hope to augment the learning experiences and clinical training for our Ghanaian trainees across medical specialties and surgical specialties. We want to engage in collaborative relationships to start to cultivate medical education as a distinct area of expertise with a long-term goal of developing a faculty of medical education within the Ghana College of Physicians and Surgeons. We're going to start off today with a lecture on OSCEs. And during the OSCEs presentation, the chat function will be open. I hope you can put all questions if you have into the chat box, and then I will read them out loud to our facilitators, who then hopefully will provide us answers. Following each session, we're going to be offering a link for evaluation. We would appreciate any and all feedback that you have. Then we're going to have a second session on debriefing after a short break. And after the debriefing session as well, we will have a link for you to provide us feedback about the session, and then we'll wrap up and hopefully end around 1800 today. So without further ado, I'm going to hand over to my colleagues, Dr. Simmons, Dr. Reindorf, Dr. Whitman, and Dr. Stojan, who are going to present us with our first presentation today on OSCEs. I'm going to stop share and allow Dr. Simmons to take over.
Thank you so much, Dr. Ting. So my name is Dr. Efe Chantal Ghani Simons. I am very, very excited to be here working and speaking and connecting with you all, in part because I'm originally from Ghana and I grew up there, and I had the opportunity to come to the United States to further my education. And I'm currently a urology fellow, so I completed a urology residency training at UCLA in California, and I'm a urology fellow at the University of Michigan, but also getting a master's in health professions education. And today I will be presenting on OSCEs with a team of individuals who have such a wide breadth of experience. So everything that I'll be presenting is not a reflection of one person's work or expertise, but really have to give special credits to Dr. Jennifer Stojan, Ms. Laurie Whitman, and Dr. Roderick Lawson Reindorf for helping put together this information that we'll be sharing today. All right, so we'll jump right in. We have quite a bit of ground to cover, but feel free to share questions in the chat as needed. So our goal for today, we're hoping to provide an overview of the OSCE, also known as the Objective Structured Clinical Exam, for clinician educators and medical trainees across all specialties. And as you know, this presentation is supported by the Ghana College of Physicians and Surgeons. And by the end of this presentation, my hope for you all is that clinician educators and medical trainees should be able to explain the principles and potential uses of an OSCE, should be able to outline the steps and critical considerations in organizing an OSCE, and 3, to understand how data from an OSCE may be utilized for the learner and to further education research. So what exactly is an OSCE? So there are 2 big buckets or concepts that need to be understood to really understand this process in medical education. So the OSCE in and of itself, it's a training or assessment program in which learners rotate through a series of time-limited stations. And then the other concept that is very foundational to the concept of the OSCE is the utilization of the standardized patient. So these are individuals who portray a specific clinical case in a consistent way. So the hope is that from learner to learner, what they experience with a standardized patient should remain the same. And those individuals typically, not always, and we'll come across some cases where this happens to hold true, typically they're not afflicted by the conditions that they're depicting. So in medical education, one of the tenets or theories that are foundational to the concept of the OSCE is this idea of experiential learning. So learning through reflection on or reflecting on what you're doing. We also think about how we transform the way we experience things or the way we go about navigating our identities as medical providers through experience. So really thinking about transition from knowing something to actually doing something. And then there's also a consideration for repeated, deliberate, and focused practice. So the OSCE allows us to repeat a skill to such a degree that we continue to grow in terms of expertise. So when you think about these three concepts, this cycle comes to mind. So you do something, you have an experience, then you reflect on the actions that you undertook. So you want to really take some time to think about what you did, how you did it, to reflect on that experience. Hopefully that reflection in conjunction with the action results in what we call abstract conceptualization. So transcending just the knowledge piece and the action piece, and really understanding the underlying principles and concepts. And then at that point, you hopefully will be in a position where you're able to experiment or expand on what you've learned. This also evokes Millet's pyramid of clinical competence. So again, the concept of starting off by knowing factoids, you're able to recall, and multiple choice exams are excellent for this. But then we hopefully will transcend to being able to know how. And this is more of an application or interpretation phase of the knowledge continuum. So we see this utilization when individuals are assessed through things like case presentations. It's not enough to just be able to rattle off facts. And one of the things we used to say a lot when I was in high school was chew, pour, pass, forget. That will not work here in the know-how phase. And then to demonstrate, and this is where the OSCE comes in. So simulations and experiences such as the OSCE allow the learner to have an experience where they show you how they do things, or they show you how their knowledge has transcended past factoids. And the hope is, again, to be able to get to the point where you're independent practitioners. So this is what we observe when people are working on the job. So some of the common uses of OSCE. So I'm going to share some common uses across different contexts, and then I will pause and have Dr. Larsen-Reindorf step in and contextualize the OSCE in Ghanaian medical education. So in the United States, as well as in the UK and Canada and in Ghana, the OSCE has been used to evaluate undergraduate medical education experiences. So we're talking here about the medical student, not necessarily those who've gotten their medical degree and are at the residency or housemanship level of training. It has been used as an assessment tool in the UK for assessing clinical experience. And previously in the United States, we used to have the USMLE Step 2 CS. And this was essentially an OSCE that every medical student had to do towards the end of their medical school experience to demonstrate that they were not only at the know or know-how, that they were able to show. And this is no longer the case for a variety of reasons. And then it's also used as an educational tool to provide feedback. So I'm going to stop talking and mute myself briefly as Dr. Larsen quickly goes through some of the applications of OSCE in Ghana specifically, and then I'll take over from there. So let me mute myself, Dr. Larsen, if you're able to.
All right, thank you very much, Dr. Simmons, for the intro and where you have brought us. So as you mentioned, Ghana is also using OSCE, and Cape Coast has been using OSCE from inception. That's from around 2009, 2010. They have been using it in all their exams. And University of Ghana followed around 2010, 2011. And then here in USC, my institution started in 2014. So all the 7 medical schools, 5 public and the 2 private ones, as far as what the so-called major clinical departments are concerned, that is OBGYN, pediatrics, surgery, and internal medicine are concerned, they all use OSCEs in the summative exams, the end of year exams before you are promoted to the next class. So that has been going on for about 10 years. The other schools have followed after 2014, but essentially all of us are doing it. Some of our schools may use the traditional exams during the low-stake mid or end of rotation exams, but we are all doing it. Typically, across the board, we are employing about 4 to 8 stations of in exams, and you have a history station, which is normally followed by a post-history encounter, where management is discussed, and then physical examination, and you may have a station with an image that will deal with some questions. So most of our institutions are doing about 4 to 8, a few are doing 10 to 12. And so that is the structure at the moment. Some of the challenges I think I have observed around, because beside my own school, I have gone elsewhere to examine, is the standardization of the SPs and the examiners. It's improving though, I must say, but initially the SPs were not typically demonstrating what they are supposed to demonstrate throughout the whole exams. Along the line, things may vary, but using the same group of SPs over time, I have noticed a huge improvement in that. With the examiners, yes, schools initially did training for all faculty, but I'm sure many will agree with me that along the line, we bring in people who are either senior residents or non-faculty to join in our exams. And many people have not had training. So there is a need to have training, particularly performance dimension training, where we all will study some videos we have done and make sure that the observation we are looking for is consistent. And if you've been entering in scores, like I do typically in my school, sometimes you see wide variation among examiners who are examining the same station. So that needs improvement. And the next issue has got to do with the checklist development. It's really time consuming. It takes, I typically take about 20, 22 hours to develop a history station, cumulatively. So the development puts a lot of strain on faculty, especially the team that is behind the scene and putting the OSCE together. And there's also some checklists that certainly we need to improve on the content validity, because we have some checklists that, if you take my specialty, for instance, obstetrics gynecology, it's like across from rupture of membranes to cancer of the cervix. If a candidate is able to go through the items on the checklist, irrespective of whatever is before, that candidate should be able to pass. So there's need to be improvement in the content, so that the content, if you don't really understand the case before you, you should not be getting huge scores. And then the rubrics and the weighting, the items on the checklist, assigning weights is also an issue that, in my view, we have to look at. So you greet a patient and it's 1 mark, and then you are asking a specific thing, like, say, what example should I use? A woman has jaundice in pregnancy, and you want to find out whether So you asking about the color of the urine will also be 1 mark, like the person greeting. There must be some kind of differentiation, and these are things that can be improved upon by all faculty looking at it and then determining where things should lie. I think the last thing I'll talk about with our experience here has got to do with a pass mark determination. So far in the schools, some are using a fixed 60%, and some are also using a fixed mark of 50. So it's either you are using 50% or 60%, irrespective of the difficulty of the station and other characteristics. So logistically is huge. It requires many examiners to help. If we take a number of students we have into consideration, you have to run several rounds, several circuits to put in place, and that puts a lot of strain on the system. But we've been coping in terms of space. I think all the schools are doing well with space available for the exams. Is the examiner training that I think we need to work more at. And these exams are costing a lot of money. In my institution, for instance, last year, my department alone, it was 520 cedis per candidate if you put all the financial items together. That's the equivalent of $40. So that I will leave it here, and I'm sure during question time, we can come back. Thank you.
Thank you so much, Dr. Larson-Reindorf. You really have set the stage for many of the things that we're going to talk about as we move forward through the presentation. All right, so again, speaking about core principles or tenets of the OSCE. So objectivity is really important, and in order to be able to achieve this, standardization, Dr. Larson-Reindorf spoke about standardization with regards to the patients, regards to the evaluators. And he also mentioned the scoring rubrics, how the examiners are trained, the kinds of questions that are asked, and if they're consistent, if there's consistency there. And in order to be able to have that degree of objectivity, care and attention needs to be paid to the structure of the task that is being asked of the learner. Another concept that he raised was that of validity. So being able to, is the test that you're creating assessing what it's designed to assess? And hand in hand with validity comes reliability. Are your results reproducible with little error? And again, spaces where we can hone in on this reliability are things like the design of your scoring rubric, the training of your examiners, the trainings of your SP, the number of stations that people have to experience, and the kinds of questions they are asked at each station. A big thing that we don't tend to talk about as much, because you can design whatever you want to design conceptually, but the feasibility of what you intend to do. So the degree of practicality of your endeavor, from things like cost and time and resources to be able to put things together. Now, we've already spoken about the idea that this is a resource-intensive endeavor. It takes time. Developing the stations it requires you to craft them, and you want to focus more on performance over knowledge, and so being intentional about how to facilitate that. And then we think about the educational impact. So the more similar an OSCE is to what happens in real life, the more likely that experience is going to drive lifelong learning. If the OSCE, the experience that you create with the OSCE isn't quite realistic, then what's going to happen with your learners is they're going to just compartmentalize. So they will do what they have to do to pass the OSCE, but in real life, they'll do something else. So you really want to think about how can you converge the experience that the OSCE is offering your learners to what they see and experience and do on a daily basis in order for it to be a useful tool. Now, I should pause here to mention the idea that performance is not equivalent to competence. It's very easy to assume that if someone is able to perform, that they are competent. And we all know individuals who are high performers, but may not necessarily be competent. And a model to conceptualize this by Dreyfus is the idea that the novice is someone who recognize things and is able to use rules to decide what to do. They're the person who is going to look at the rule book and say, okay, well, the rules say I should do X if Y is the case. Someone who's competent tends to be able to use experience in real life situations. They understand context. And so they don't need hard and fast rules. They're able to use guidelines to guide and not dictate what they do in terms of the actions. A step beyond that is proficiency. So here, if an individual is exposed to even a wide variety of situations, they're able to recognize patterns to inform future action. And then your expert is someone who typically has a vast amount of experience under their belts, and so they're able to pull on those experiences to be intuitive about how they approach solutions or how they approach patient care. And the gold standard is mastery. So that's the highest level of performance. Now, in terms of performance, so a person can be competent, but may not perform well on a given day or under a given context. And there's so many things that go into that. So you can think about things like personality traits. Your learner who's more introverted might have a very different way of presenting themselves in an OSCE compared to the person who's extroverted. And then your physical state. You just took a 24-hour call, you're exhausted, things that you know you're capable of doing in an optimal setting may not necessarily be what you do when you're in that particular physical state of being. Emotional state is equally as important. And the environment. So some folks don't do well in a simulated space because they feel like they're under the microscope, they're being observed. But if you observe them in clinic or in my case, in the operating room, they're facile, they know what they're doing, but they just, in that context of being peered, like looked under a microscope, they just cannot seem to perform. Attitude. So some people think like, why is this OSCE important? It's not real life. And so they may go into the experience with such a lackadaisical approach to what they're doing that even though they're competent, they may not perform well. And then there's so many non-clinical skills that go into the care that we render in real life that may not come across in an OSCE. And then motor skills. So in surgery, you think about this a lot, hand-eye coordination, and your knowledge. Like if you have a weak foundation in terms of your knowledge, your performance is limited by that fact. So then if I've mentioned to you how performance can be situational and can be contextual, why should we do this OSCE? What are some of the benefits that it may afford us? So things like instilling confidence in students, because they get this practice ground where it's okay for them to actually make mistakes because it's in fact a training tool. Because when you identify the holes in a learner's fund of knowledge or ability, then you can make concerted efforts to improve or fill in that deficit. It potentially could allow for deeper and more meaningful learning, and it allows you to assess skill in combination with knowledge. And I've kind of mentioned this ad nauseum, the idea of standardization, so that we're not as likely, and this is not foolproof, but we're not as likely to inject bias in how individuals are evaluated if everyone has the same experience. Now, the disadvantages I've also somewhat touched upon. People can compartmentalize the experience in such a way that it doesn't allow for durable learning or real life translation to real life experiences. And there's the short duration of this. You do an OSCE for an hour, but in real life, you're going through these situations every single day for years on end. How is an hour going to capture that? There's a resource intensiveness of it, time consuming, and you might have the questions or the scenarios leaked. And so if you're not able to assess all your learners at the same time, those who are evaluated at a later time may already know what they're going to be asked and may perform better as a result. So we're going to get into the meat of things, the nuts and bolts. These slides are going to be shared, so if you miss anything, please feel free to reference the slide. And I'm just kind of going to go through very quickly so that you have a bird's eye view. So these are the 10 steps of organizing an OSCE. I can't take credit for it. This is pre-existing work that has been published, and the references will be at the end. But we'll walk you through these 10 discrete steps. First, you want to identify your available resources. It takes a village. So this is not an I kind of work, it's a we kind of work. So you want to have a team of individuals who are going to do this with you. You need to find a location. So if you're gathering all your learners to do this, typically you're going to have to find a space that can support that. And then you need funding and institutional support. So you may have this brilliant idea to have an OSCE. If your institution says, no, we need the learners on deck, that we need them to be providing clinical care, you might run into some issues. Once you've done those three things, another thing that you would want to put together is a budget. And I'm just going to quickly rattle through some of the things you might want to consider. The space might have to be paid for. You may need medical supplies depending on the skills that you're trying to assess. Almost always, maybe not entirely the case in all experiences, but you might want to record because you want to be able to go back if there are any issues between ratings that you're able to review the performance of your learners. So recording, and that comes with a cost. If you intend to utilize the data that you've acquired for a number of reasons, for the sake of the learner, for the sake of furthering education, medical education, research, then you're going to have to figure out a way to have a repository for this data and analysis of this data. So anyway, the cost is what I'm getting at here. You need to work on a budget. So we have this example for you. Now, the second step is you want to agree on some goals and timelines. So one OSCE is not going to be able to do everything for all learners, right? So you might want to break things up into chunks. So what is your goal for this specific OSCE? What is your timeline for it? And which individuals are going to be responsible for the discrete goals or the discrete tasks that you set for yourself? This way, come game day, on the actual day of the OSCE, you're not looking at each other being like, oh, I thought you were going to do this. I thought you were going to do that. So really clearly outline your tasks and have some deadlines. I tend to be someone who has internal deadlines for everything. So in addition to your hard deadlines, you might want to put some buffers so that if there are things that need to be workshopped, you have sufficient time. Okay, so the next step here would be establishing a blueprint. And so this is where you kind of work on the nuts and bolts of the OSCE itself. So you want to think about things like, are the cases that you're considering, are they representative of your typical clinical practice? Are the cases representative of what has been taught in the course or in that rotation for your learner? Do the cases adequately cover all the competencies to be tested? So all the competencies you intend to examine. Are there diagnostic and management challenges that are varied in a systematic fashion? So if you're going to have differences across the group, and remember standardization is the name of the game, you want to be very intentional about how that variance is being done. Is there a balance in terms of the gender? So you either might want to have an equal division or resembling your real life practice. So an example is in obstetrics and gynecology. Your patients will mostly be women. And so saying that, no, we want to have an equal split of gender in that case is not realistic. So you want to think about those considerations. In addition to things like, do you have a variety of patient ages that are represented, a variety of cultures or backgrounds that are represented? I include race here, and that's something that's very salient here in the United States. But I would argue in Ghana, you would want to think about the different ethnic groups. Do you have someone from the north versus someone from the Volta region or someone from Accra? The different languages, we don't all speak every single language in Ghana. So thinking about the complexities that happen in real life care. And this is an example blueprint. It's not necessarily the end all be all, but this is just an example that I want you to have available. And our next step is to actually develop these cases and the stations. So what are some of the considerations as we develop the cases and stations? So are your station goals clear? So do they provide precise information about what the station is supposed to teach or assess in terms of what learners need to know and what learners need to be able to do? So when a student or a medical trainee goes to this station, it's very clear that this is the skill we're trying to elicit, and this is the lesson we're trying to teach here. So you want to be very clear about the goals of each specific station. Is the case appropriate? So you want to consider the level of training. If you have someone who just started medical school and the station is asking for a very complex counseling for maybe end of life, and this person is day 2 of medical school, or maybe let's say the 2nd month of medical school. You want to really think about the level of training and the appropriateness thereof. And then also think about the content, what they actually learned in their courses, and if it correlates with the assessment that you're conducting. Is the time adequate? Can the task be managed or at least initiated in a given time? Are the learner's instructions clear? Can the learner quickly ascertain what the situation is and what needs to be done? Are the instructions uniform across cases in terms of the format and length? So you have one station that has 2 sentences for the instruction, and the other station has a whole paragraph or maybe a page or 2. Well, then they're not going to have adequate time to be able to conduct the steps or to perform what you intend them to. Are the standardized patient's instructions clear? So do they provide adequate background information for a standardized patient to actually take on the role? Do they clearly indicate the key elements of the case? So things like not just the content, but what is the emotional tone that the standardized patient should have? What is the timing with which they should provide information? And for faculty, the faculty instructions clear? Do they provide adequate guidelines on how the faculty is supposed to proceed? Do they include appropriate station-specific teaching points, and how feedback should be given once the experience is over? And then you also want to think about the feasibility of simulation in the allocated time. So is it possible to simulate the physical or psychological signs or symptoms that you're requesting? For example, do you want the SP to appear depressed for 10 minutes? And how possible is it for an individual to do that over and over again for 100 students? Will you need to have multiple SPs who sub each other if it's a stressful scenario or a difficult physical finding that they have to manifest? And then we go on to creating your rating form. This is something that Dr. Larsen-Reindorf mentioned can be incredibly time-consuming. With the rating form, there are 2 big buckets that you want to think about. So you want to think about your global rating form items, and then you also want to think about behavior-specific rating form items. Those are 2 separate things that you're assessing. You want to be cognizant of that. Now, with the rating forms, as you create them, you want to conceptualize the competencies needed to perform the station task well. So for example, are we looking at communication skills here and physical exam skills and history skills? What are the competencies you're trying to hit in this specific station? You want to compare that conceptualization with other available standards. So if in the literature, other people within your specialty, or maybe not in your specialty, but other people have looked at what an acceptable standard is, then you have sort of a blueprint or a guide to figure out how to assess your learners. Again, not a golden rule. Then you operationalize the competency to turn them into written items. So you go from, this is the competency I want to assess, and then you create a question to support that, assessing that competency. You want to determine the rating option. So is this a checklist of, yes, they performed this action, or no, they didn't perform the action? So one of the examples Dr. Larsen-Reindorf mentioned was the learner walks in and they introduce themselves or they greet, done. But versus a scale, how did they greet? Did they, have eye contact with the individual? Did they shake their hand? Did they not? Did they appreciate that the culture of this individual, perhaps they're not, in terms of the gender relations, they're not allowed to shake hands? So really thinking about, do you want this to be a yes, no, this task was completed, or versus a scale? And then you want to create behavioral anchors to help your evaluators, help them help you. So you want to create these anchors to help the evaluators identify which rating option to select. So you might say things, for example, if they did this task or this action more than once, then that equals a score 3 versus a 4. So help them figure out how that scale, what each of the values on that scale mean. Then try it out. Pilot the rating for multiple times with multiple different people at multiple different levels. And with that feedback, you refine your rating form. Then the SPs, and there's a lot to dig in here. So with the SPs, your selection of the SB will determine what you will have to do, or what extra effort or not you would have to do in terms of training them. So when you think about someone who has not had any acting or has had some acting experience, they may have an easier time listing like emotional responses if that's something you require of them. So you might have to do less work in training them. If they happen to be individuals who have are healthcare professionals, they may have a better understanding of the learner's role or any technical issues, what you're looking for, so that might help you. If they have no personal expertise with the case, that may or may not be a benefit, but they have less emotional engagement with the case. So maybe they don't know anyone who's had cancer. So if they're acting a scene that involves malignancy, then there's no emotional valence there. Personal experience, like I said, the reverse. So they might have disease-related specific knowledge, which may or may not be a good thing. You want to be careful with that one, because you want to be respectful of the standardized patient's their own confidentiality and their own being able to protect their privacy. And then you might introduce an issue with standardization there. If one of your SPs has had that specific disease process, but the person who subs the next day hasn't. Typecasting. So if you choose someone who falls in that general, has characteristics of a general group or population, you're less likely to have to teach them how to react and act. The subtle things, though, I mean. If they've had prior SP experience, that might be helpful. If using an SP who has background that's relevant to your case, you might not need to give them as much history. And this one is a tricky one, and I think about this a lot since I'm a urologist, but comfort with physical exams and invasive physical exams. So just depending on context and what people are comfortable with and what people are trained to do, you want to be very careful how you navigate like the GYN and the obstetric and gynecology exams, as well as urologic exams. So in creating your standardized patient training protocol, here are some considerations. You provide a training program overview. So this would include when and how to get where, who will they be working with, what are the program objectives. You really want to be as detailed as possible. Explore the SP's expectations and concerns. So don't wait till the day to ask them, do you have any concerns? Because their concern might be that, well, actually, I'm not comfortable having a student do X or Y. And the whole time you've been having them do that. So you want to ask ahead of time, what is it that they're expecting? What are their boundaries? What are they concerned about? Review the individual cases with the SPs. They might actually provide some insights with regards to how you tailor the case. Have them take turns reading aloud the learner instructions so that they have a sense of the perspective of the learner. Have them read their own instructions to make sure it's clear and makes sense to them. Let them read the rating form, because that might inform how they actually go about acting, because now they know what you're assessing. Review a video sample and encounter. And I think Dr. Lawson Reindorf mentioned this as well. This is helpful for the nonverbal cues and nonverbal behaviors. The video assessment is particularly helpful for that. So have the SPs demonstrate to each other. So you might want to ask for a volunteer instead of having one person or assigning one person to do it and say, no, you did that wrong. If you have someone volunteers to demonstrate how a particular case or a particular station should be run, and that way they can all troubleshoot as a group to refine what your expectations are. Videotape and practice the encounters that kind of has already been mentioned. And the SP should practice with each other, not just with you, the medical educator, but hopefully with each other as well, in order to reduce the anxiety that may be associated with this performance for them. We think about the learners as well, but this also has impacts on them. And organizing a formal trial. So I strongly recommend doing this in the space that the actual OSCE is going to be held, so you can see what transitions also look like, where is time being wasted, how can you be more efficient so that you run true to time in terms of your schedule. So best practice for SP recruitment, a lot of this just kind of makes sense. If you have really good SPs, they might know other people who have similar skills. You want to cast the right person for each case, so pay attention to that. For your high stakes programs, or if you have a high stake exam, you really want to think about cross-training people, because what if that day that individual has an emergency and can't show up, and then you're in a pickle? So you might want to consider cross-training with the individuals that you have available. So if there's one person who is scheduled to be an SP from 10 to 12, you might want to have them be ready to go from multiple different scenes, so that you can have people move around as needed in an emergency, and have a backup for every single case. Put the SP into the learner's position before game day. So it might be helpful to have the SPs role play as the learner. There are situations where the SPs take their jobs very seriously in such a way that they might actually make it challenging for the learner to be able to demonstrate this skill. In order to generate some empathy on their end for the learner's experience, have some of the SPs role play in the shoes of the learner, and that might actually inform how you alter things. You want to practice all aspects of the encounter. So oftentimes when people do a trial, they only practice the actual interaction between the SP and the student, but you want to practice the feedback portion too. You don't want to leave anything to chance. And think about the psychological and physiological impact that this experience has on the SP. So say you have an individual who has to practice or pretend that they're limping, and your exam runs for a week and they're working from 8 to 5 p.m. They're constantly limping. That might have some ramifications with regards to things like muscle spasms for the SP. So they're people too. So be mindful of what your expectations of them are and what the impact is. And then train all the SPs who are going to be doing the same case. So if you have multiple SPs who are definitely going to be doing the same case, train them concurrently at the same time, same resources, so they're seeing and experiencing the same thing in order to facilitate your standardization. So we're getting closer. How are we doing on time?
We're doing good. Continue.
Okay, so recruiting and training your evaluators. So this can be a tricky thing, because you have people who are volunteering their time to help you with this experience that's taking away from their busy clinical practice. So you want to really help them help you in this situation. So in terms of how they're evaluating, a big part of that is observation. They're looking at what the learner knows, what are their skills, and what are their attitudes with regard to what they're doing and experiencing. And so some of the things that as an evaluator, you want to prime them to think about is inappropriate focus. So is the learner doing too little, too much, or are they paying too much attention to one small, minute portion of what they should be doing? So that would be inappropriate focus. Halo effect here refers to one observation which is easy to obtain or of great significance, such that it influences the rater's perspective of everything else. So an example is you have an evaluator who's looking at the student, and this student comes in and they check the blood pressure. They did such a good job using the manual blood pressure. They're so impressed by them that everything else they do, even if what they're doing is subpar, so subpar by the standard that you set, they've already made that good first impression, and that rolls over to how you evaluate them for everything else. The converse is also true, and I tell my mentees this all the time: reputations are sticky, first impressions are sticky. So be mindful, or remind the raters to be mindful that their first impression of a learner should not necessarily block them from having any other ways of viewing that particular learner, so that if they're aware of their bias from the get-go, they might be more cognizant of being more equitable and fair in their evaluation. Is the observation too short or too long? So if the learner didn't give you much, like you wanted them to have a whole counseling discussion about like an end-of-life case, and then they spoke for 2 minutes and they stopped and they said thank you and they left the station. So premature closure or insufficient information. And what is the difference in the actual points of your scale? So we make these scales, these Likert scales, usually from 1 to 5, 1 to 10, and we don't really help the evaluator know what the nuance is from point 1 to point 2, point 3, point 4, point 5. So anchor your scale with specific either tasks or observations, so that they are able to have better standardization with the scoring. Some raters have different styles. There are some who tend to just rank everybody a 5, the highest possible score. And there's some raters who say everyone is going to be a 1 if they're first-year medical school students. They won't be a 5 till they graduate this program. And there's some individuals who always will choose the number in the middle. So you want to prime your rater to understand what their rating experience or style is. And the mom effect here speaks to the idea of people not wanting to the expression I think I heard a lot when I was growing up is pull him down syndrome. You're not trying to cut someone else's experience at their knees or undermine someone else. And so because there's a perception that a poor score or a not so favorable score is punitive, there are people who would just give everybody a great score because they don't want to be that person. You don't want to be that person who gave a poor score. But if you think about this as a learning tool to allow for growth, hopefully that will change the mindset of the raters. So, spoke about observations. And then when we think about judgment, how should I rate this training on a specific item? So here are some things you can share with the raters to help with that. I kind of touched on this a little bit. There are people who gravitate towards the extremes. There are people who gravitate towards the mean. And this is called a central tendency or end aversion bias. So you want people to be aware of that. You also want them to be aware of a concept called homophily or similar to me effect. Oh, we're from the same hometown, we speak the same language. And so when we find people, and this is a natural human tendency, it's not something that is necessarily malicious, but being aware of that or making sure to mention these things to your raters before they go into the experience will make them more mindful. And then contrast effect error. So trainees are evaluated against each other instead of the standard. So we decided that anyone who is able to perform a cystoscopy, for instance, and place a ureteral catheter, that is the floor, that is the baseline. Then you have 10 students who all come in and try. One student is able to do even more than that, a ureteroscopy in addition. Now, everybody else is being judged against that one student, even though we had predetermined that that was not the standard. So pitting the students against each other in terms of how they're evaluating. You want to be mindful, of course, and we all think about this, generalizations, prejudices, and stereotypes. And here, if the standards are not fully understood, or if there are unclear expectations for a specific training levels, it just makes it difficult for people to judge, so decide those things beforehand. And then in terms of what they're actually writing on the sheet, and issues you might have, incorrect recording, so make sure that you remind them to fill things out the way you want them filled, or inadequate or missing comments. All right, so how do we train these people? We've spoken about all the things they could do wrong and all the things that could be barriers. So again, a lot of this is similar to the things that you would do for the SP. You want to provide a training program overview, everything from where they should be, the nuts and bolts of the day itself. Again, you want to explore their expectations and concerns beforehand. You want to review the case to be observed and rated, and provide them a copy of the rating form when they're reviewing the case so they can point out to you some holes that you may have missed. I also would recommend, again, having the rater go and experience what the learner is experiencing, and that might make for less harsh evaluations. You want to review typical rater errors that I've already shared with you. And introduce the raters and the SPs together. They shouldn't meet on the day. They should, if possible, you want them to meet ahead of time so that they already have developed a rapport, because typically they're in the rooms together. So having them have a shared understanding of what is going on would be helpful. And then in terms of feedback, so some people give feedback in real time. Some people would do a formal evaluation afterwards, then give feedback. There's some OSCEs where the SP gives feedback, the rater doesn't until a later time, or then there's combined feedback. So you want to provide a framework. Don't leave it to chance. Discuss ahead of time who is going to provide feedback and when and how, so that there are no surprises with regards to that. You want to introduce characteristics of effective feedback, so have some sort of training for that specifically. It's important that we focus on behaviors that can change and not personality, and take advantage of all the observers in the station. So you've got the raters, you've got the SP, you might have other individuals. You might want to lean into their perspective. Provide feedback anchors, so teaching points that are specific for the case that should be covered to strengthen the overall message. And then you want them to practice, like anything else, practice giving feedback. So the rest of this should be fairly brief. Implementing the OSCE is exactly what it sounds like. So things that you want to pay attention to is you want to have all the orientation materials that you need, and information and materials for your SP and your raters, the rotation schedules. That's going to take a lot of time. Post-OSCE evaluation forms, you want to have that at the ready, and faculty program evaluation as well. Things to consider in optimizing your OSCE. There are some time considerations, I think, that we've kind of spoken about quite considerably. Don't forget your admin staff. So we think about the students, we think about the SPs, and then the medical educators. Your admin staff are critical. They're sort of the choir conductor to this, also to all of this. So you want to make sure you have someone who's invested and who has the time and is compensated, ideally. And contingencies, have extras of everything, extra SPs, extra forms, extra props, because you just never know what might happen. Now, for me personally, these last 2 points are of particular interest, thinking about managing, analyzing, and reporting data, because my medical education interest is in medical education research. So you do this incredible thing that is a learning opportunity, and you have the opportunity to gather data and be able to iterate and improve. So for that, you're going to need to have software to collect that data. So a few considerations here. In your data entry, it's better to use an entry form format. So something like a Qualtrics, or thinking of some other software, RedCap, instead of a spreadsheet, because you're more likely to introduce error in a spreadsheet if you're entering your information there directly. Whatever format you choose, just make sure that it's one that allows for easy exportation into a statistical software, or at the very least into Excel. If you're going to use the data for anything that's beyond communication directly with the learner and with educators, before you do the OSCE, do yourself a favor and have a conversation with your version of the institutional review board, so the IRB, to make sure that you get approval. And then you might want to consider in the data entry, so as maybe the learners are coming in and signing up, you might want to have a system to generate unique identifiers. It might be as simple as having every student have a number or a letter on an ID that they wear, and that would be what you use for your subsequent analysis if you want to use this for research, not necessarily for the learner's particular feedback. And then calculating and interpreting the scores. This can be challenging to do especially if you hadn't predetermined. So what is your standard or your baseline? And there's a whole lecture that we can give about standard setting, but you want to think about, is this a pass-fail endeavor? Is there a range that you're looking for, and how can we preset that? How do we provide feedback to our learners, to faculty, to the SPs? You want to think about that as well. And then think about evaluating the program. So that's different from assessing your learners, but evaluating the program. What went well, what didn't go well, what can we improve, what can we work on? And don't be discouraged, because every endeavor will have things that can be improved. Here, I'm just going to quickly mention some key points, and I'm happy to talk offline with people about this. Again, these slides are available. But in your evaluation of your data, you want to consider certain psychometric qualities of your results. And I spoke to you earlier about reliability. Internal consistency is also important. So are we measuring consistently, or what we did, does it measure consistency and precision as an assessment tool? And if the learners, do they undergo the same exam without any interim intervention? Will they have the same results? And do similar trainees perform similarly at different stations? So you want to think about the reliability and consistency. Then intra-rater reliability here measures consistency of individual raters over time. So if a rater would evaluate the same performance the second time, will they get the same result? And there's I apologize, there's an error here. So the first should have been intra. So same individual, would they give the same score if they had to evaluate a learner? Inter-rater reliability is different raters, will they give the same learner the same score? And then validity, we've spoken about this as well. Are we measuring what we think we're measuring? There are different kinds of validity, face and content validity. Does it look right? Convergent or divergent validity, does it compare to other measures as it should? Predictive validity, does it predict future behavior? So those are concepts that you want to think about as you are analyzing your data. And reporting your data, you're reporting to your learners, as I mentioned, to performance feedback. You may want to consider whether you want to report this relative to their peers or relative to the standard or both. You want to look at whether, in terms of reporting, whether you're within the domains you expect it to be within. And then lastly, here looking at developing OSCEs across your institution. So Dr. Lawson-Reindorf mentioned that OB obstetrics and gynecology has been doing this, but what are other people doing at your institution? So you might want to consider collecting your data within an institutional server so that allows for easier collaboration. And to that end, create a collaborative interdisciplinary OSCE committee that meets regularly. So emergency medicine might be doing OSCEs, OBGYN. How can we learn from each other, pull on resources, and avoid pitfalls that other people have already discovered? You want to engage your institutional leaders. So this is a thing that if the, you have leadership in medical education, be a part of or be involved in, so that you can get them excited. That will allow for you to have more likely get resources behind you, and disseminate your findings, even if it's not like something that can be published as a publication for a journal. It can be presented as a poster, it can be presented in your own department, in regional conferences. So think about how can you share what you've done. It's helpful if the budget is not something that has to be generated ad hoc every single year, if it can be built into the departmental budget. And I recognize that there might be a number of barriers with that, but if you can aim for that, that might be helpful. And then if there are specific research and or education grants, those tend to be smaller amounts that may cover the OSCE. That might be something to explore. And publish and present, as I said, locally at your institution, nationally, internationally. So that, I know that was a whirlwind. I hope this was helpful. I appreciate your kind attention. And as promised, the resources will be, and references will be included in the slide, so you can actually look at the primary literature yourself. And I want to again give special thanks to the team of individuals who helped me put this together. The pictures and their names are here. Thank you again. And we're happy to take questions. I'm not sure if anything came in through the chat. And if time doesn't permit, I'm also happy to talk offline.
Thank you so much, Dr. Simmons. Thank you so much and your team for the whirlwind of information regarding OSCEs. It is such a tool, and it is such a vital tool in both teaching, point assessment, as well as continual assessment in our trainees across the spectrum of medical education. I know it's come quite a long way since I was a medical student in 1905, so I look forward to how it's going to continue to grow as time goes on. We are running a bit behind on time because I started late. So I would like to draw your attention to the chat, folks, where I have placed the Qualtrics survey that we are hoping you will take a few minutes to give us some rapid feedback on the session that we just had. We also want to give you the promised break for roughly 10 minutes. So we are right now at 5:10 GMT and 1:10 Eastern Standard Time. So we'd love to give you the 10 minutes and come back, everybody, at 5:20 p.m. GMT and at 1:20 p.m. Eastern Standard Time. Dr. Simmons will stay around with us, so she will be available to answer your questions through text or through the Q&A function on the Zoom link. But thank you so much again, you and your team, for this wonderful presentation. All right, we'll see you all back in 10 minutes.
I just wanted to tell you how great of a presentation that was.
Wow, trying to keep up with time. Welcome back. We are now at 20 minutes after. Hope everybody had a chance to get up and walk and move some blood through their lower extremities. We're going to come back with our second set of lectures. And our second set of lectures are being brought to us by two former colleagues of mine who are now in St. Louis, along with a former trainee of mine who is in Ridge Hospital in Accra. So we're going to hand over now to Doctors Boateng, Stringer, and Thomas to help us better understand simulation and sort of debriefing after simulation, which is often a vital and critical skill in that learning process. So I'm going to hand over now to Doctors Boateng, Stringer, and Thomas.
Thank you so much, Rocky. So I guess as we're closing the day, it probably is a little ironic or appropriate that we're closing with debriefing after simulation. So earlier in this series of seminars, we had a presentation on simulation, the actual execution of it. But today we are out to talk about the juice being worth the squeeze of debriefing, how we sort of get the most out of our efforts in simulation design and execution. So I'm Jenna Thomas. Again, I was previously at the University of Michigan, both for my master's in health professions education and my education fellowship. And I will let the other two illustrious colleagues of mine introduce themselves as well.
Hi there, I'm Sam Stringer. I did emergency medicine residency at University of Michigan and am now in a medical education fellowship and completing my master's in health profession education. And Dr. Thomas and I are together at Washington University in St. Louis right now.
And I am Nana Ifia Insua Boateng. I'm an emergency physician at Ridge Hospital, and I was trained with Rocky. Thank you.
That's fabulous. So without further ado, despite, I'm sure, what is all of our best efforts, we have no financial conflicts of interest for this talk. This talk is also targeted at sort of a general medical education audience, people who are not necessarily simulation trained, but who integrate simulation into their daily practice as teaching, may help with simulations, may design some simulations and lead them, but are not necessarily angling for a director or educator job. And finally, we do have some extra resources that are specific to simulation training at the end of our slide set, which we will send out. I realized as I was going through that we sent out to Rocky a version of our slides, which doesn't include our references, so we will update that and send it out, and it should be available to everyone at the end. So a few things that we want to accomplish by the end of this seminar today. We want to be able to answer some pretty basic questions about simulation debriefing, specifically the kind of why. What is simulation debriefing? How is it different from just giving regular feedback? Basically, why does this matter? Why should we approach it differently? Where does this fit in with medical education theory in general? Why is this based on medical education theory, and how do we sort of fit this into our practice when we are debriefing? Some frameworks practically that we can use to set up a debriefing session, sticks based on where we are in the world and what we have available to us to optimize these debriefing sessions. And of course, where can we go to learn more in case we have a greater interest in this? So to jump right in, what is debriefing? Why is this different than feedback? What I want to do to oversimplify things a little bit and then build from there is to consider debriefing as a guided reflection, in a sense, after an event. So to jump into this, feedback is one of my favorite topics in medical education, and the word feedback, of course, actually comes from electronics literature in the early 1900s. It is this idea that the output of a system or the product of a system can be used to put back into the system, either to accelerate it or put the brakes on it. So negative feedback being the output is used to dampen the system's output, positive feedback being to amplify the system's output. In essence, again, putting on the gas, do more of this, or putting on the brakes and saying do less of this or modify this. So debriefing then is kind of this formal, systematic process of questioning of somebody, of a learner, of a participant, in order to get an idea, draw out from their experience what happened or what was done, what are the lessons that we're taking away. So this is when Tom Cruise goes on Mission Impossible and his superiors, his managers in a sense, are not with him on this mission. When he comes back, they do a debriefing session with him to glean everything that they can possibly glean from what he experienced and what they can learn from the mission that he went on. So this is very similar to what we do in the debriefing process with simulation. So again, feedback, exceptionally important teaching skill. It's especially for those who are really good at this. It can be widely applicable to pretty much every situation in medical education. However, it is dependent on 3 different things. So feedback is dependent on both an event that is observed by the person that's going to be giving the feedback, the initiation of a conversation about this event, either by the person who experienced it, the trainee, or the supervisor. And then finally, whatever the supervisor's context for the event in the sort of realm of the learner's educational context they have. It may have been a random chance that they observed this event. It may have been something that they meant to observe, but it really is dependent upon what the feedback giver knows about the learner's knowledge, the learner's goals, the learner's larger educational context, which affects the feedback that is given. Now, debriefing, again, is much more structured in a sense. It is a systematic process, and it also depends on several different things. An event that is observed, a discussion that is initiated, and the supervisor's context for what was going on, the educated person's context with educational context. So what is the difference then between feedback and debrief in this setting? What does debriefing have that feedback doesn't? The first thing is going to be a wise observer. So wise in the sense of this person already is prepared for and knows what is going on. They're wise to the context of what the learner is expected to learn, the learning goals. They're wise to how this scenario, the simulated scenario, is going to unfold, and they have some measure of control over that. And they're also wise to what they want to get out of the session. So they have a great context and a preparation for this session that maybe people who are just giving feedback don't necessarily have. Also, both the learners and the facilitators in this setting know that there is going to be a space and a place for debriefing afterwards. They know that there is going to be a discussion about what happened ahead of time. It is an expected, normal thing. It is not necessarily sprung on them out of nowhere. So there's preparation for a conversation about the event as well. And then finally, there is protected time for this conversation. So not only is there a protected space and an expectation that it is going to happen, there is a time that is protected from any other kinds of interruptions. For example, feedback often happens in the clinical space. That conversation may be interrupted by clinical needs and patient needs, patient care issues, or department flow issues, particularly in the emergency department where many of us work. But in simulation debrief, this is a protected space. No one can interrupt this particular time. So what can we do with the expectation that we're having a debriefing session? Well, as we kind of learned in our previous session on the simulation learning objectives and the structuring of a simulation scenario, there are several different types of learning objectives that we can make for every specific scenario. So there are the cognitive objectives, the things like diagnosis and treatment, medical knowledge things that you would expect a learner to know, that you could basically draw out just kind of with some Socratic questioning of a learner. There's also, in debriefing, you can really use this to draw out some of the affective components of the simulation. How did learners feel during the simulation? Did they manage their emotions appropriately to achieve the goals that they wanted to achieve? What was their risk tolerance? When did they pull the trigger, in a sense, on executing a decision? These can really be targeted as learning objectives in a way that we might not get if we just used feedback. And then finally, we can make explicit a lot of these psychomotor objectives that we have for learners. So things like managing their space that they're functioning in. Maybe they have less space, less resources, different resources than they're used to. Maybe it's performing a procedure in a way that they might not have expected beforehand. And we can really make this, draw this out and make explicit and talk about these psychomotor aspects for learning. So again, some of you may have recognized Bloom's taxonomy in that last slide, and we're already getting into a little bit of the educational theory about how debriefing works. So we're going to jump into that a little bit more, keeping in mind that debriefing is at its core a guided reflection on an event that was observed and took place. So Kolb's experiential learning theory essentially frames learning as a cycle. So in the context of a simulation experience, we're going to start with having a simulated concrete experience. So once this experience is to some degree complete, then we go down and we start to guide reflection as facilitators. This is why we call simulation facilitators rather than teachers. Really what we're trying to do is facilitate this debriefing session where we get learners to review and reflect on what concretely just happened. And then our hope during that session, we structure it such that we can lead them to sort of abstract and conceptualize some learning points from the experience by analyzing and talking about what happened. We can also add in some facts, some things to consider that we can do a little bit of teaching within here, but really it's this initiation of the reflection and then guiding them to abstract from this that is part of the debriefing experience. From there, we expect that learners are then going to go out into the world and then have another concrete experience, hopefully in clinical practice. So something like if we did a simulation on managing hypertension in the ICU, we would hope that at some point in the future, they would also have an experience where they were managing hypertension in the ICU. So then they take exactly what they learned, what they conceptualized during this debriefing session after a simulation experience and apply it in real-time clinical practice. So they kind of experiment with these new things that they've learned, put them into practice, which then of course results in another concrete experience, but this time in the clinical setting. So within this, really what we're doing again is reflection. We're facilitating this reflection. So when this takes place after the event is finished, this is considered reflection on action. So it's something that has already happened and we guide people to reflect on what has happened. Consider the situation. Think about what you would do differently next time, but think about what needs to be happening in the future. But there's also a more immediate type of reflection that happens that we can incorporate into debrief, which happens during this active experimentation and concrete experience part of the cycle. And that's called reflection in action. It's the real-time incorporation of the feedback of the scenario. I learned this, I tried this result, and this is what I'm going to do next. That's the reflection that is actively happening, called reflection in action. And as Dr. Stringer is going to point out soon, this is also something that we can target with debriefing in simulation. So these two theories are not necessarily the only education theory that comes into the necessity of debriefing for simulation. Erickson's deliberate practice theory also has this idea of repeatedly coming onto and experiencing this learning by doing and then reflecting on it. There's also a social learning theory, which really talks more about the need of learners to observe, imitate, and model things in their learning environment in order to come onto new information and to change behavior. So if you're interested in that, again, we will have a couple of references that will be available for you when we finally send out our corrected slides here in a little bit. So we're going to move on to debriefing, and Dr. Stringer is going to share her slides.
Yes, just give us about 30 seconds and we're just going to change presenters. If anyone has any questions for Dr. Thomas right now, go for it. Okay, so the next few sections is we're going to talk about how to plan and execute a debriefing session. And so the first part of this is there's 3 different main approaches to debriefing. So the first is facilitator guided post-event. I think this is what most of us think about when we consider a simulation debriefing is, we have a simulation scenario that the learners go through, and then after that, we have a debriefing session that a facilitator guides those learners through. The second is a little bit less common, but this is a learner guided post-event. And so it's similar in that those learners go through, a simulation scenario, but instead of having a facilitator guide them through that debriefing, it's the learners themselves that guide each other through it. This is typically done with either a cue card or some questions that are pre-prepared for those learners to go through. because this takes a lot of kind of self-direction, better for senior learners. And really the big con of this is kind of if that group of learners are, you know, either reinforcing something that might not be best practice, there's no facilitator to kind of correct whatever kind of thought or behavior might be going on. But there has been there's not a whole lot of evidence on learner guided post-event, but some that it does change behavior in learners. And then the third approach is facilitator guided within event. And this is also called rapid cycle deliberate practice, if anyone has heard that term before. And so this is when the debriefing for the scenario actually happens within that simulation scenario. And so what this practically looks like is the facilitator will time out the learners to either highlight something that they really liked that the learners did, or maybe something that could use some improvement. And then they'll debrief upon that learning point and kind of talk about it. And then the facilitator will rewind that learner to a certain point and have them go through that same scenario again. And so the goal of facilitator guided within event or rapid cycle deliberate practice is really for mastery and for muscle memory. And so where we in our institution use this is really with algorithms. And so one example is we have our residents go through newborn resuscitation, Mr. SOPA, that algorithm using rapid cycle deliberate practice. And another area that I found this approach is really helpful is when we're doing communication-based cases. So for example, you know, teaching junior residents how to give a death notification. We'll use this approach because it allows them to, you know, say what they want to say. And then, you know, we can say, kind of time them out, discuss kind of the positives and again, what could be improved. And then they get a chance to try that again. And so they can really, again, kind of master whatever skill they're trying to learn. So what frameworks do we use to do the actual debriefing? And there's many out there. This is in no way inclusive of all of those. We're going to talk about 3 frameworks here, and some of the most popular ones. And it's also a mix of simple and complex. So you have some different tools based on kind of the time and the situation that you are debriefing in. So the first is called plus minus delta. And you as the facilitator, you're going to ask 3 questions in the debriefing. What went well? What didn't go as well? And what will you change for next time? And so as you can see, and these are 3 simple questions, and this framework is really good for those scenarios where you don't have as much time to debrief as you'd like. And so one example is in situ simulation or kind of in the clinical space, where you want to debrief that simulation, but you don't have, 20, 30 minutes as people need to get back to their clinical responsibilities. Another framework, and we're going to spend the most time here, is called debriefing with good judgment. And the basis of this framework is we as simulation facilitators have the assumption that all of our learners are intelligent, they're compassionate, and they want to do their best and do the best for their patients. And so the goal of this strategy is to use that assumption to kind of understand what the learner's clinical reasoning is behind whatever actions that they do in the simulation. And so this framework has 3 phases. The first is reactions. And so this is really an emotional debrief. And so what this looks like is we sit down and we start the debrief and I say, how's everyone feeling right now? And that allows them to kind of unload any emotions that might be going on, about the scenario or about kind of whatever, disease process, et cetera, that you're teaching. Because if they're holding on to some emotion about the simulation during the whole debrief, that takes up cognitive load and they won't be able to really understand and retain the learning points that you want them to retain. The second phase is analysis. And this is where you're going to spend the most of your time. This is when you kind of talk about the actions that you observe during the simulation, and also the pre-planned learning points that you come up with. And we're gonna come back to this phase, because again, this is the majority of the debrief. And then the third is summary. This can either be done by the facilitator or by the learners themselves. How we do this in my institution is we have all the learners go around and give one take-home point from the simulation. All right, so let's go back to analysis. And so a concept that I want to introduce here is something called advocacy inquiry. And I'm going to give you an acronym here to go through. And the point of this is not to memorize anything, but really just to give you another tool to kind of address actions and behaviors that you observe in a way that doesn't come off as judgmental or make learners feel shame or anything like that. And so we're going to go through this acronym. It's called PALE. And then I'm going to give you an example of what that actually looks like in real life. So the first here is preview. And so this is when you tell the learners, let's talk about X. Advocacy is when you're going to say what you observed. So I saw Y. And then you're going to say why you either liked or disliked that. So, I saw Y and I'm a little concerned that it could cause X. And then you ask, what were you thinking when that was going on? So that you can really listen to what the learner's clinical reasoning is. And so this is what this looks like all together. And I'm going to give an example of recently when I used this and it went over very positively. And so I was doing a simulation for medical students. They were preclinical medical students that were getting ready to start their clinical rotations. And so the simulation scenario, I don't remember the exact details, but the patient was hypoxic and they had to put the patient on oxygen. And there was a delay in doing that. And so in our debrief, I said, let's talk about this patient's hypoxia. I noticed that the patient was hypoxic to the 80s for 2 to 3 minutes before oxygen was placed. And I'm worried that this could have made the patient sicker. What was going on in your minds when that was happening? And what I got from these medical students is they said, they were like, we know the patient needs oxygen, but we didn't know what device to put on or how to place it and how much oxygen each one could provide. And so through doing this, it was just what I observed. There was no kind of negative judgment. And then I could understand that it wasn't that they weren't paying attention to the vital signs or they didn't know that the patient needed oxygen. I got to uncover this knowledge gap that allowed some really kind of rich learning that I think that they will retain well because of that. And so this is just a kind of a visual example of changing that clinical reasoning. And so the actions and the results that we see here in this diagram, that's what you observe in the simulation. And what we're trying to get to is these frames, which is just another word for kind of their clinical reasoning or clinical thinking. We're trying to get to those to see if we either need to reinforce that or maybe try to alter it a little bit for the future. And then the third and last framework we're going to talk about is called PEARLS. This is not introducing any new big concepts because I know we just talked about a lot of things. This is very similar to debriefing with good judgment. And this is a great infographic that shows the different phases along with some sample sentences on how to do this. This is just so you have this to reference. We're not going to go through all this right now. But what I do want to point out here is, again, these are very similar to debriefing with good judgment. It just adds that kind of setting the scene in the beginning of the debrief of kind of what you're going to talk about. And then this third phase description, which I actually do in most of my debriefing, and that's making sure all the learners are on the same page and that they know what the scenario was. And so just naming what, the diagnosis was, et cetera. And then, so planning, a couple brief points for me, and then I'm gonna pass it on about planning, is time. And, like everything in education and academics, time is really important here. And so you want your debriefing length to be twice the length of the simulation. So if the simulation is 10 minutes long, you want to make sure you have at least 20 minutes to debrief that with the learners. And then the second here is preparation. And so this is preparation by either you as the facilitator or the person who's writing the simulation for others to facilitate. Is you should have some pre-planned learning points to talk about. And then you should also kind of anticipate what challenges the learner population might have with this simulation, so that you can kind of come up with some questions or ways to address that ahead of time. Again, there's always going to be things that happen in the simulation that you weren't prepared for, but at least having some prepped learning points. And then I will pass it on to Dr. Botang, and she will talk about faculty and more in our next section here. And I will advance your slides for you if you're okay with that.
Yeah, thank you. I'll be okay with that. So when my co-presenters and I decided to split the topics, it was said that I do implementation and logistics. And what I came up with is mostly through research, and I put some questions together and I asked my medical officers and my nurses and people who have actually worked in the Ridge ED before and have somehow left the shores of Ghana. And these are some of the things we came up with. The first is to optimize debriefing in our setting, we need a faculty. And the faculty sort of becomes the recognizable structure for which both facilitators and participants get to learn and create the awareness where debriefing. I remember one of the things that I read about was debriefing is one of the things that simulation talks about, but it is put so far down below the food chain that when it gets there, people just brush over it and we don't really talk much about it. And there's a general apathy here in Ghana. I remember when I started Ridge, most of the time, when we finish with a case, I want to debrief and talk about it, but people are like, what is she talking about? And over the time, it just vanished. So because there's not really an understanding as to what it is really about. So if there's a consistent approach, it promotes familiarity, and every time there's a scenario or there's an event, people would want to debrief on. Secondly, what systems have we put in place for others to know what debriefing is about? What are the protocols in the clinical setting? And one of the people talked about our administrators. They are really important in this setting. What have they put in place for us? What are we putting in place for ourselves? What is the criteria regarding when and when not to initiate debriefing? What do we do to emphasize its importance, both as a quality control measure and also to help our staff deal with emotions and stress after an event or after a scene has been put in place? One thing that Jenna also talked about was instructor and facilitator participation. Next slide, please. Instructor participation or facilitator participation. Most of the time, like I said, because there's a general apathy as to debriefing, we who have been put as team leaders, who have been put as instructors, do we participate enough when it comes to the debriefing schedule? When there's an event and when we are done, do we just brush it off, or we call and ask for particular debriefings? And because mostly people have perceived the case already as it's going to have a negative outcome, the general consensus is, why do we need to talk about it when we know that the outcome would be negative already? But these things help with knowledge and create opportunities for learning. The next is on our finances. Finances focus on things like cost versus benefits. Is there sponsorship, program development, maintenance, and research? And this is where our administrators come in a lot, because most of the time we focus on whether there's technical skills, knowledge, whether the outcomes are, rather than what the economic impact is on. And these are the things that our administrators want to focus on. So we want to have stakeholders who understand what the resource implication is and how we need to use these simulation-based training for them to help us develop a program, to task trainers, to use VR, virtual reality, to use mannequins, to use whatever it is to help in maintaining whatever it is to help with the debriefing. And its research is also needed to cover resource requirements, cost categories, cost estimates, and the like. Next slide, please. And in our setting, especially in our low research setting, how many of us have accessibility to our simulation-based training centers? I remember looking on the net to look at how many simulation-based training centers we have in Ghana here. And all I came up with was UGMC, University of Ghana Medical College. There was nothing to show that maybe RAGE has an anesthesia training center, which has a simulation lab. There was nothing to show that there are other centers in Ghana that show that they have training centers. So how is it that we in Ghana, how do we have training centers? Is it occupied? Is it available if you want to use it? You need to pay certain things before you're able to use it. All these things are put in place and must be assessed before these things happen. Then we move on to our logistics. Logistics, training the personnel. Do we have a team? Do we have debriefing champions that are going to help us with the course? What hospital policies have been put in place? What local policies have been put in place? What legal jurisdictions do we have that shows that this is a confidential matter, and then there is it cannot go out after being taught? It cannot go out. It should remain as where it is. Have we allocated roles enough, or we are just there and waiting? Is there enough education? Is there a quality? The education, where does it come from? Is there feedback? Are there formal courses for us to do? All these things are what we need to put together in place for us to know what debriefing is about. So, basically, take-home points is debriefing creates new opportunities for learning, and its implementation. sorry. Its implementations in a variety of settings is really, really important. It's where learning happens. It helps to let us reflect. There are frameworks which Jenna mentioned, a lot of frameworks that we can use. It helps to allot time enough for us to know and to learn our mistakes and to learn where we were culturally inappropriate or where we were psychologically down. And we need to understand that every institution has a barrier, and facilitators implementing evidence-based debriefing helps to maintain the status quo. Thank you.
And again, here are some of those further resources that we talked about, and they will be in the slides that are uploaded. And we'd be happy to take any questions that anyone has. Thank you very much for having us.
Thank you again to Team Stringer, Team Thomas, Team Boateng. We appreciate the knowledge you have shown all of us today. I'm just looking in the chat to see if there are any burning questions that people have. Please feel free if you want to unmute and ask a question or pose a topic for discussion. I know during the presentation, Dr. Boateng had talked about the difficulty sometimes knowing where some of these resources might be available. And I believe in the chat, someone had mentioned that there are several institutions in Ghana who have simulation centers. But again, the question is, how accessible are they? Who can access them? What are the processes by which you would assess them? How do you, is it available to me? Is it available to my residents? Is it available to my students? So on and so forth. But some of these, I think, are coming along as the college is leading in these discussions about, we have resources in the country that we could use as adjuncts, as other ways to sort of improve the training that we're providing. It's a matter of being aware of them and then being able to utilize them appropriately with further training. Dr. Reindorf.
Yeah, thank you. I just wanted to quickly add that when it comes to the plus minus delta, there's always a tendency to start with the negative. So it's always something that we need to prompt ourselves, that because maybe during the simulation, the candidate did something really bad. And so the moment they finish, you're just ready to pounce on them, and all that. But we really need to control ourselves and first talk about what went well. So the candidate will say what they saw first, then you also introduce what you saw first before we go into the negatives. And I've tried this with medical students. Sometimes when they do a presentation, then they ask, so what went well? The first person wants to talk about what didn't go well. And so when we do that, it helps the resident take the negative when they're able to see that it's positive. So I'm just stressing that when we want to use that, let's stress on what went well first before we go to what didn't go well. Oh.
Thank you, Dr. Lawson. That's a good point. I think it's Sam that mentioned that it's often difficult to add to knowledge, right? When the person who's doing the learning is scared or in some way emotionally affected by the initial comments that are made. And this is a skill that we continue to learn as you interact with students and different individuals. Some people react differently to your initial statement. So being aware and creating sort of a space in which the learner knows that this is about learning and not about, gosh, you did something wrong, but hey, I'm mentioning this because I think you can do it better. And I know if we talk about this, then it'll get better. But people don't learn when they're scared, right? People don't learn when they're upset. And this is something that we all have to get better about, in being able to provide a space where we can look at what has happened, describe it, talk about it, and then use it as a learning point to move forward. Yeah.
I agree with you, Dr. Oktang. I think that one of the biggest benefits that I ran into when I actually started using one of these structured debriefing frameworks, specifically PEARLs, is just naming those emotions and normalizing them, saying, wow, what are you feeling right now? That was stressful. That was frustrating. That was, scary. And just normalizing those emotions oftentimes then elicit learners to be able to say those things and be like, yeah, that's how I felt. I felt scared. I felt this, I felt that. And then being able to talk about it and say, okay, and then, what happened, and talk about how those emotions sort of affected the scenario. So it's really that debriefing, drawing out what was happening, naming what was happening, that I think has made the biggest difference in my practice of debriefing, is taking that time to make those things explicit.
Yeah, I completely agree with Dr. Thomas. And I think another thing that I've run into a lot is, you'll ask this question of how's everyone feeling after the simulation, and you get a lot of fine, okay, but like you can tell that's not how they're actually feeling. And so really trying to say, sometimes we'll say something like, who was like stressed about like that situation? Because I'm feeling stressed as, the facilitator going through that. And that also allows people to be like, yeah, I'm actually like not feeling great about it. And so that's another common issue that I run into a lot, is having to really pull those out.
I think
and on the point of the earlier sort of conversation about where there are simulation centers and the resources that you kind of have to set up these simulations, we've had a lot of success with in situ simulations. So if you do have a clinical space that's available for a period of time, actually going in and doing a simulation with the resources you have available in a clinical space, if it's not taken up at that time, is really helpful. And it's actually quite realistic to what was going to be happening in real life. So there's not necessarily a need for a fancy simulation. You don't have to have high fidelity mannequins and that sort of thing. In fact, for most of our simulations, we don't actually heavily use really, really high fidelity stuff. It's more so, sort of having one of us be the voice of the patient as they're looking at a mannequin, or actually having one of us be in that scenario. So it can be actually quite effective to kind of forego the bells and whistles and just focus on what you're actually going to be dealing with in that clinical space. It's a great way to get your nursing staff, your ancillary staff, and everybody else who would be involved in such a scenario involved as well, because they're already there.
I also just wanted to mention that I have now posted the survey for the second session in the comments. If you would mind, please just taking a minute to give us any and all comments that you have about what you've heard, what you've learned so far, what we could do better or add to our ongoing series. That would be super helpful.
Rocky.
Yes, sir.
Yes, I want to find out your views in the US concerning the SPs. Knowing the sensitive nature of exams and how things should not leak, do you sign an agreement with them as to what to do and what not to do before you engage these SPs?
Yeah, so we do. I know our standardized patients are professionals. I know here at Michigan, they are a professional group, as in they are recruited, they are trained, they are retained actively to be part of this ongoing process of training, especially our medical students. And so I know that there are requirements for them around the secrecy, like what things can they discuss outside of their role, what things can they discuss with people who are not involved, versus certain things that they can only discuss when they're in that SP role. So they do sign some sort of agreement about the things that they're going to see, the things that they're able to discuss. But they are a professional group at the end of the day. They are hired on and sign a contract that this is what they're going to do. They often have different roles that they play, different patients, different, the same group might be used by ONG, the same group might be used by emergency medicine, the same group might be used by surgery to help train their folks. So yeah, that's how we go about it.
That's a very good information you've given. What we normally do, I mean, apart from the general training that has been given, the nurses and midwives we use, they get to know the case about an hour and a half before the exams, and then they are taken through how to play that role. Yeah, thank you very much for the information.
Yeah, I think, as in all things, I think you get what you pay for sometimes, right? If someone who is dedicated to playing a specific role regularly and does it for medical students and residents and whatnot, is obviously going to give you a better product than someone that is just available that day, right? There's a lot of medical pathology that is so rare that if you waited to encounter it as a clinician, you may never be ready to address it. But there was a question about specific tools to evaluate OSCEs when the exams are over, or is it relevant to ask students about what their thoughts are about an OSCE? Would anyone, Jenna, Sam, I know you got to go, like to comment on that real quick?
Yeah, we evaluate OSCEs in a couple of different ways. So we certainly ask for student feedback, although if the students don't like it, it doesn't necessarily change things. It's, kids don't like eating vegetables, but they're still good for them. So we make them eat their vegetables. So that's the kind of analogy that I use there. So, if a student says, I don't like this is stupid, that doesn't mean we're not going to do it. But we do get, we'd get feedback from faculty on the cases all the time. If we're going through a case and the faculty say, maybe this should be tweaked, that should be tweaked, we certainly do that. We ask standardized patients for their feedback. No matter how well we prepare for an OSCE, there will be questions that the students ask that you'll say, wow, I had no idea that someone would even think to ask that question. You know what I mean? So when we put them together, we pilot them, we run them, we get feedback year after year and sort of make them better. But there's not a specific tool to evaluate, there's not a gold standard specific tool to evaluate one. We just sort of get evaluation data from the standardized patients, the faculty, and the students.
Right, and the voice you're hearing there is Dr. Stojan, who is my boss in some ways, who runs our doctoring course here at the University of Michigan. And that course is a longitudinal course that teaches our medical students a variety of skills, from physical examination to a session we just recently had about spirituality and religion as it relates to patient interactions. So she speaks from a place of experience in dealing with evaluations from both students, the standardized patients that they employ, as well as faculty who are involved in putting together some of these educational sessions for the students. So thank you for that.
I'm sorry, I'm under Rockefeller Otang on here. I don't know why.
I think you use my link to log on, so it comes up as me. But you make me sound smart, so I'm gonna take that. All right, folks, any other questions or comments about the session? All right, here we go. There's a question that came through, says, do you recommend that faculty are given protected time to develop OSCE questions meeting the high standards required? Dr. Reindorf, what do you think?
I think so. I think so. It takes so much. And when you have a team, but we do end of rotation assessment, and then you do the main exams, and sometimes it drains you so much you even dream certain questions and editing questions, and it's a lot of work. So we should have protected time for some of these activities. End of the day, assessment is one of the big pillars as educators we focus on. So there must be protected time for that.
Yeah.
Just to top up, I agree that we should have protected time. Sometimes it's a bit difficult in our settings to actually delineate what time we are talking about, whether it's for the college or it's for the university and all that. Sometimes it's a bit difficult to draw the lines quite sharply. But what I notice is that this burden is left on very few trainers. And that's usually where the trouble begins, because maybe once you're a chief examiner, everybody just comes to the exam waiting to see a beautiful exam setup. None of them is bringing you any scenarios. You ask people to give you questions. They don't show up with the questions. And so few people are burdened with this task over the year. So I think that's this training should open that door, so that within the faculties, we should begin to train each other and encourage each other to write the questions and use the same what went well, what didn't go well. Because sometimes when somebody brings something and all we have to say is, oh, this is not standard, I don't think we can use it and all that, then you discourage the trainers from producing more. So I think that the chief examiners within the departments and then within the faculties should begin to expand their scope and start roping in more trainers. Whatever question they said, you give them a scenario, whatever question they said, work with them so that they polish it, so that over time, maybe every faculty is getting 20 or 30 trainers, setting, giving them scenarios for OSCEs that we need about 10 per exam. I'm sure within 5 years, we'll have so many scenarios that that burden will become much lighter. So I would suggest that we do that in addition to negotiating for protected time to do some of these things over.
Yeah, Prof, that's a great point. There are, I know here at the University of Michigan, there's a structure that creates protected time, but that structure isn't free. The protected time is paid for. Someone is paying for that time. And it's a matter of where that funding is coming from or who's paying for that protected time. For example, when I had research funding from the NIH, for example, that would pay for, say, 30% of my clinical time. So the 30% time that I was going to work clinically, now I would have to dedicate towards research or things of that nature. When it comes to medical education, it's the same. For my role in our doctoring course, I do get some time that is away from the clinical environment, but that's dedicated to then the education of the medical students and being part of that faculty and development and coaching students, mentoring students, and assessing them as well. So sometimes it comes to an institution, like what is the institution willing to put forward to support the improvements in education? as Dr. Lawson just talked about, I think this process we're going through now, where we are introducing this idea of people who are really focused and have spent time gaining further knowledge about medical education, who are then creating and helping colleagues with techniques, with approaches that are standardized, such that we can get better products and get more people who are interested, such that it's not one person sitting for 3 days trying to come up with an OSCE, right? If it was a team of 10 people or even 5 people, then the burden is spread across multiple people, and you get better products too, because everyone has different perspectives on questions or what things that they might find interesting, or what things might actually test someone's competency or capabilities. In the comments, I saw a question about how do you handle students you think know the answer but are sinking with trepidation? Would you be objective if you provide some assistance? Jen, you want to touch on that for us? If you're still on.
You know, it's hard in an OSCE situation. We just let it play out, right? So that we let it play out, and then the students get assessed, and then afterwards we have a grading committee that looks at all the scores for all the students, looking at the mean, looking at the standard deviation, and then also looking at the student performance through the last couple of years. And in that, you know, in that we then develop remediation plans and meet with the student and tailor a plan based on what they need help or what they're sinking in. Does that answer the question?
Yeah, I think so. I think, you know,
we don't correct anything in the moment.
Right. I think when it depends on when the assessment is happening, right? In an OSCE, in a formal OSCE, this is a formal assessment, right? So if you think they know the answer, but they're unable to express the answer, that in itself is a deficit, right? And I think letting it play out, observing it, and then going back once a formal assessment part is over, and working with the student to figure out what was it that was inhibiting them from being able to express themselves, right? That's where then the learning occurs, right? If you're in the session, if you're in the session with them and assist them, that sort of defeats the objective nature that you want to establish when you're doing an OSCE.
Yeah, Rocky.
Yes, sir.
Yeah, for quality assurance purposes, do you recall some of your exams in Michigan so that later on you look at examiners, everybody, and improve the quality?
Yeah, Jen can speak to this, but yes, gosh, I forget the name of the center, but there is a whole floor that is dedicated to the learning arts in this fashion. The rooms all have cameras, everything's recorded, even the practice sessions. So in my doctorate course, I have 4 or 5 students that I'm responsible for teaching, for example, the cardiac exam. Like, how do you examine someone when you're saying I'm doing a cardiac exam? So they have in-classroom learning. We have hands-on learning that we do in the center. Now, even in that session where I am teaching them the skill and they are practicing having to learn it, this is not a test, this is just a learning session. It's recorded, you know, so that one, the students have access to go back and watch themselves do this thing. The faculty have the ability to go back and request and see, hey, can I watch that again to see maybe what I didn't say right, or if something didn't go well, can we watch it and see what it was that didn't go well? If the standardized patient who's in that session helping us learn has a concern or raises a concern about something that happened during the session, it's not their word versus somebody else's word. There's video evidence that's recording the whole thing. So there are multiple uses for recording. One being, you know, if an issue occurs, you can look at it and others can watch it objectively. 2, if there's an issue with the grading or the assessment, others, besides the one who's responsible for the assessment, can watch it and say, hey, I agree with how they assessed that person, versus, no, I think they did that skill. I think they asked that question. I think maybe the assessor, for whatever reason, missed it, right? So recording these sessions and having the capability to watch it, there's so much value in that. I know some of it when the students either do well or don't do well, when they go back and watch themselves, they do so much self-reflection and they learn so much from watching themselves interact in these situations. It is of huge value, at least from my perspective.
I agree. And I think the other thing that's nice is that we actually are able to evaluate our standardized patients. So, we're giving them the script, we're letting them, play the role, but we're actually able to do quality control on the people that we hire and their ability to portray the patient by watching it. So not only does it help the students, but it helps us from like a human resources HR standpoint to be able to decide if the people that we hired are actually doing the job. As Rocky pointed out, there's lots of reasons why the students may go back and watch, or someone else can double check, but also I find that it's really good for student self-reflection. When a student doesn't do well on something, especially with OSCEs, a lot of times students say, this isn't real life, this is a fake patient, and they don't necessarily have the buy-in. But if you go back and say, now watch yourself at minute 12, right? See how you are approaching this, see how that is not necessarily the way to do it. A lot of times I think that students have this perception that they did a great job, but when they watch it, they realize, maybe I didn't.
Okay.
All right, folks, we have eroded into your evening now. It's 6 p.m., 6:15 p.m. GMT. I wanted to thank all our presenters and all the folks who took the time to join us today. I take your joining as having an interest in medical education. Please join me, Dr. Reindorf, Dr. Lawson, and thanking everyone for taking the time for joining us today. We have more sessions coming up. Please look for your WhatsApp notifications and join us again in the future to learn more about the interesting field of medical education. If anything we've talked about has sparked an interest in you, please reach out to us, as we are really trying to create an avenue, especially between the University of Michigan and the college, create an avenue through which we can help folks really gain the further knowledge and become sort of experts like Dr. Stojan and Drs. Thomas and all the folks that have been on with us today. I hope you all have a good evening and enjoy the rest of your week.
All right.
We should say thank you.
So we'll meet on Thursday, 9th May. That's our next session for Thursday, 9th May. But it's Thursday, not Tuesday, please. It's Thursday, 9th May. Thank you all.
9th May.
Bye.
All right, guys. Thank you all.